Well, hello everyone. I'm going to start talking. Can someone just say through the chat facility, yes, if you can hear me and you can see me, please? Good, thank you very much. Okay, there's a few people coming on to the meeting, that's good. This is 9 a.m. on Tuesday, the 29th of September 2020. So this is week 4, effectively week 3 of teaching, week 4. Today is the first of our 4 guest lecturers, and Mr. Edwards is going to come online at about 9:10, and I will introduce him formally then. I've asked him to start speaking at 9:15. Jim Daly, who's with us at the moment, is a university learning kind of technologist, and Jim helps us in so many ways. We checked the links with Andrew Edwards last week, so hopefully the technology should be work. And perhaps if I may offer you some advice, always good when you've got a presentation at a conference or a congress or a lecture or a guest speaker to check the technology beforehand. So Jim and I did that with Andrew last Thursday. Now, before Andrew comes on at 9:10, parish notices to go through. Remember again, please, the assessment dates that I set you. Oh, incidentally, I'm recording this lecture. A couple of people have asked me to record the lecture. So if you talk or if you raise a question, please be aware that you're being recorded. It's really okay because I also want other people. We run this module in Singapore, and I want the students in Singapore to hear these guest lectures as well. So it is being recorded. Now, assessment dates. Remember, the assessment for the module is made up of 2 components, component 1 and component 2. Component 1, red line in your diary, please, 30th of October, which is just over 1 month away, the 1st of October being on Thursday. A couple of mics are live, guys. If you could just maybe switch your mic off, if that's okay. And component 2 on the 11th of December, just before Christmas. We will get the module all finished by Christmas. Next week, there will be no lectures or tutorials because next week is week 5 and we do the ESP, or the Employability Skills Programme. So we'll get that out of the way next week. So you might be pleased that you will not see me next week. And we'll start the following week. And rest assured, the following week, I will start to talk in detail about getting you fully prepared, or prepared fully rather, for component 1. And I'll start going through how I would structure the essay, how I would approach it. And remember, the key points are to think about the strategic level of analysis and how organisations, in terms of their leadership at that strategic level, have responded to COVID. Now, over the last week, a few of you had said, well, Brian, can I choose an organisation? No, you choose the organisation. And actually, that's why I like reading your work, because you tell me about organisations I had never heard of before. Organisations in every corner of the planet, small organisations, big organisations, charities, private sector organisations, public sector organisations. So it's really okay to go with your own organisation. There is no right, there is no wrong answer, but what I'm particularly interested, and I will keep on going on about this, particularly interested in, is how has the leadership at the strategic level of analysis responded to COVID? What has the organisation done to ensure its survival? Because we have discussed at length at the strategic level of analysis, the purpose of leadership, in my view, is to actually steer the organisation through the metaphor, the choppy waters, to make sure it survives. And there are some great examples on the planet right now of the organisations are trying to do that successfully. Okay, I'll just close down that chat so I can see everyone. And then component 2, the 11th of December. Now, so more for the components after ESP. Tutorial this week, a couple of announcements for those. Dr. Janice McMillan has been asked teach. So therefore, for the tutorials that Janice does at 4:30 on a Wednesday and 5:30 on a Wednesday, i.e. tomorrow, you will have noted that I have put an announcement out that these lectures, these tutorials are not taking place. So please do not repeat, do not turn up at the EICC for Janice's tutorials. You are very welcome to go on to the online tutorials at 10 a.m. on Thursday by Dr. Pratton and 2 p.m. on Thursday afternoon by Dr. Young. Britta, Dr. Heidel will still do the earlier tutorial on Wednesday afternoon, so that's okay. And the tutorial this week, which we commence with today, I do the first two on a Tuesday, 3 parts. It will be important to consider your downstream effects of leadership. And I'm going to ask people to try to understand what leadership means in terms of people who receive leadership. And that could be performance, psychological aspects of leadership. We'll do that. We are an academic institution, so therefore it's very, very important we actually drill down into such words as etymology, which is a great word, and you will come across that word many times in your lives. Etymology is kind of where did it start, where did it come from, and we started to drill down into the etymology of leadership. And although that is academic, to ask you in the context of your practice leadership in organizations, once we have understood what that means, how then will that affect your further thinking about how you are going to lead? And I keep on coming back to this, i.e. how you're going to lead other people. And the final part of the tutorial is I'm going to ask you to have a look at the chronological definitions of leadership. And what's very interesting of that analysis is you'll see how much people interpret leadership differently. And where I want to go with this is to start to think actually about where in your working lives in the next 30 or so years, how the definitions may change, how you may want to lead other people, but of note, how other people may want to be led by you. And we'll do that in the tutorial this week. But rest assured, as soon as we come back online after the ESP, the lecture for week 6 or week 5 of teaching will be ready for you to have a look at, and we'll just crack on in week 6 all the way through to Christmas. Now, I can see Mr. Edwards online now. I don't know if you can hear me, Andrew. He's certainly there. So what I'm going to do is, Andrew, could you just let me know if you can hear me, please? Can you talk?
Hi, Brian. Good to hear you. Hear me well?
Yes, I am. Okay. Well, what I'd like to do is, just before I introduce Andrew, Mr. Edwards, are there any questions through the chat facilities that anyone has about what I said for the first 9 minutes about assessments, tutorials next week? Andrew, we're recording this lecture, if it's okay with you, because we run this module in Singapore and we run it online so that other people can listen to what you said. Okay, guys, what I'd like to do is just go on. I know other people might come online and introduce Mr. Andrew Edwards. You may be aware that once a doctor becomes a surgeon, she or he drops the title doctor and they become to Miss, Mrs. or Mr. So Andrew's professional title is Mr. Edwards, and it's very important we respect that. Andrew is from Scotland, he's from Dundee, and actually he is dual qualified as both a dentist and a doctor. Andrew studied dentistry at the University of Dundee, graduating in 1987. He then did some dentistry work before actually going back to university again, this time at the University of Aberdeen, and studying medicine. And he graduated from the University of Aberdeen as a medical doctor in 1998. He left surgery and he did his training in general surgery, notably focusing on such areas as colorectal, breast and vascular surgery, and I became a fellow of the Royal College of Surgeons in terms of general surgery. But as a dentist, maxillofacial surgeons, for me, tend to focus on someone's face. So Andrew decided to specialise in maxillofacial surgery, and I know very well that he spends most of his professional life. Well, there's a couple of mics live. Can you switch off your mic, please? Spends most of his professional life operating on people's faces. And as I said to a couple of my students in the tutorial last week, I used to be reminded, a surgeon told me once, you've still got to be pretty brave to stick a knife in someone's body. And Andrew sticks a knife in someone's face on a daily basis. So maxillofacial surgery, he's lectured, he's presented significantly globally, but he has a keen and developed interest in the subcontinent, and he spends many times a year in India, Hong Kong, and if not, a couple of years ago in Pakistan. So he likes that part of the world. He's lectured and presented widely. I used to teach with Andrew. He was director of dental examinations in one of the oldest medical establishments in the world, the Royal College of Physicians and Surgeons of Glasgow, between 2016 and 2019. And last year, he became Dean and Vice President of the Royal College of Physicians and Surgeons of Glasgow. When I wrote the book last year that we used as a core text, Andrew was one of the first persons I thought about, because in many respects, academics do not own the subject of leadership, and we've all got something to say about this great subject. And someone who runs a big theatre has got a lot to say about the subject. Without embarrassing Andrew too much, he is the absolute real deal. He is the real deal. And I've invited Andrew along to talk about half an hour about what he thinks of leadership, why he thinks it's important, what leadership looks like to him at the coalface of an operating theatre. And to my pleasure, he's also going to talk about some of the challenges he's had to overcome in the COVID situation. So, Mr. Edwards, thank you very much for coming along. I know you're a very busy man. Andrew has always... Hello. Can we switch the mics off, please? Let's switch the mics off, please. Andrew started off this morning already doing a ward round checking his patients. So to get Andrew online for half an hour, I'm very grateful. So Andrew, it's all yours.
Hi, good morning, everybody. Brian, many thanks for that very kind and somewhat humbling introduction. It's very good to meet up with my good friend, Professor Howison again. We go back a long way, and Brian has got a long association with the Royal College of Physicians and Surgeons in Glasgow. I'm at work today, as you can probably see, so it is a working hospital, so hopefully we won't be disturbed for the next half an hour, 45 minutes. So what I'd like to do is just share with you some of my thoughts around about leadership, what it means to me, and also as well talk a little bit about what's happened in the UK and actually globally with COVID, and also share a little bit of my leadership as well in the college as well. So there's a few facets to the talk this morning, and I'd be delighted to take any questions at the end of it. So through the wonders of technology, I am going to share my screen with you. Hopefully that screen should be shared now. I get a thumbs up from Brian, hopefully.
Excellent. It does, Andrew. It looks good.
Marvellous. Thank you very much, Brian. Good. So as Brian said, I'm dual qualified. I'm a consultant maxillofacial surgeon, but I'm also Dean of the Faculty of Dental Surgery and one of the Vice Presidents of the Royal College of Physicians and Surgeons in Glasgow. My day job, well, what do I do? As Brian quite eloquently placed it, my area of expertise is in the head and neck region. We deal with oral malignancy, which you can see a tongue cancer there, facial malignancy, apologies to the people who are a bit squeamish this morning, but that's a resection of a facial tumour. We do facial orthodontic surgery. We can move faces around. We can move the bones of the face. And a significant amount of my time is dealt with facial trauma, as you can see with the cases on the right-hand side of significant facial trauma, a lot of it as a result of interpersonal violence, but the one at the top was as a result of a road traffic accident. And as I say, I do tend to travel all over the world doing that. So that's my day job. My other job, as a way, it's the Royal College role, and I enjoy this role because it's like chalk and cheese, basically. get to travel around the world. I get to do a lot of fantastic lecturing. I meet a lot of fantastic people. I have the ceremonial role there. You can see one of our ceremonies at the Royal College of Physicians and Surgeons of Glasgow, where we admit our new members and fellows. They come from all over the world. As I say, the bottom left there, you can see there, that's my lifelong pal, Mr. Kennedy, who's also a maxillofacial surgeon. Brian's probably looking at his medals. He's a colonel as well in the Territorial Army. He's in charge of the Scottish medical unit, basically, in Scotland, and he's also a maxillofacial surgeon, and we go back a long way, so it's nice to do that. So that's the college role. So what am I going to focus on, really? First of all, as a surgeon, basically. Now, Brian probably told you, Brian and me used to lecture quite a lot on theories of leadership. Brian would talk a lot about the academic side and the theories and stuff like that, about particularly modern leadership. But as you can see, there's a statement there by Galton way back in the 1800s. He states, "Are leaders born or are indeed leaders made?" I think that I was certainly not born a leader. I had to learn quite a lot about leadership, and I'm still learning to be a leader, basically. There are certain theories, if you feel free, there are books, wide number of theories written about that. In the late 70s, there was Hersey and Blanchard's theory. There was 4 bits of telling, selling, participating, and delegating, and then became this one of transactional and transformational. I tend to be the sort of transformational type of style, basically, according to Burns. And Goleman and his friends came up in 2013 with these sort of, I would call these a little bit more coercive, authoritative, affiliative, democratic, pace-setting and coaching. So there's lots of theories around leadership. I'm not going to dwell on that. I'm just going to dwell what I feel leadership is and how it is important to me and in the environment that I work in. So what does it mean to me? I think this is a very good thing. This is a quote from our leadership in organizations. And I like this quote here. It talks about a process, which leadership is, and facilitating. It's a good word, facilitating. I like that. Individual and indeed collective. And what we mean by that is teamwork, basically. And I'll come on to that later on, describing what teamwork is. And it very much is teamwork, accomplishing. We have shared objectives. Our shared objectives at the end of the day is our patients, basically. That's what we are. We have a shared objective. And our shared objective is the care and indeed well-being of our patients. So that tends to summarises leadership to me. A process, facilitating, meaning to help, and also the individual, but more importantly, a collective goal, basically, or a collective objective to share a collective goal, basically. So I quite like that. That sort of sums up to me quite eloquently, really, basically. As I mentioned, I'm part of a team. I have a surgical team, and these are surgical teams in 3 different areas of the world. The one there on the left is that's my operating theatre where I was in yesterday. That's my trainees, my registrar, my junior trainees, my scrub nurse, my sister in theatre. And then you can see me in India, in various areas in India. This was in Chennai in the top right, and this was in Bengaluru in the bottom right as well, basically. So you can see there's as I say, I don't like the pink scrub suit somehow or another. They seem to put put me in a pink scrub suit there, but it's a team. It's very much a team. And what do I mean by a team? Well, at the heart of the team is the patient. You can see that. But if you're ever a patient, or have been a patient, or God forbid you ever end up in hospital yourself, there's multiple teams that contribute to your well-being. And I only farm one part of that. And you can see that at the top there, the surgical team. As you go around the clock face, we've got investigative team. We need to do a lot of investigations. You're seen as an outpatient. You may well be seen in the primary care, which is your GP. I require an anaesthetic team to put my patients to sleep. I require a scrub team to help me with the operation. Afterwards, the patient will go back to the ward, so we have a ward team. Then I have what we call the managerial side of it, basically. I need managers to help facilitate my operative work, my day-to-day work, basically, and I need secretarial support as well to communicate with both my patients and indeed my peers. If some of my patients end up in critical care, we've got a critical care team. The non-medical therapeutic support team, these are things like pharmacists, for example, physiotherapists, a whole load of other support teams that are required, and the post-operative team, obviously, once my theatre has ended my patients going to the post-operative recovery. So you can see there, I am actually a team. I lead a team, but I'm only a small part of other teams which are led by other people. But we all focus on one individual, and that's the patient who's at the heart of our care and the heart of what we do, basically. So what about this surgical team that I'm in? What do I mean by effective leadership? Well, we have sometimes critical situations in theatre, and you need to have clearly defined leadership roles. People will look to the person who will take control, so you need to have clearly defined roles there. You need to be appropriate to the clinical situation, so everything needs people to be quiet and to focus. Other times you can be a little bit more jovial and a little bit more laid back, but it's using your own style, your own behaviours, your own ethos to manage that clinical situation. There needs to be clear focus and clear direction from the leader of a team. They need to have clear instructions. However, as a leader, you need to seek the input of your team members. That's paramount important. And I'll talk about later on when leadership fails and what happens when we don't get that input or we ignore that input from team members. So that's vitally important. And these team members, we engage them all, basically. All these are all what I call stakeholders at the end of the day, basically. We all engage with each other. We all talk to one another. We're all important part of it. Each person's voice counts, basically, from the very junior member of the team all the way much to the very senior member of the team there. So that's very, very important, is engaging with everybody, seeking everybody's input to the good of the patient. So what do we look at, basically? Well, I've got a lot of personal qualities. Obviously, everybody has, basically. And it's important you have your awareness, self-awareness. You're able to look after yourself. It's very important that, you know, if I don't look after myself, who's going to look after my patients, basically, at the end of the day? That's what I say. So particularly in this day and age with COVID, and I'll mention a little bit about that. And it's not just your physical well-being, it's your mental well-being as well, which we look at. We're always driving for improvement. We're always looking to better ourselves. We're always looking for new ways to do this, and this always benefits your patients. And also, you've got your personal integrity, your probity, your own morals, and your own moral compass, basically. You set the direction. The direction is setting of direction there is basically what your goals are and where you're going, basically. And at the bottom is what we maintain is what we call about delivering a service, basically, because at the end of the day, that's what the NHS has to do. It has to deliver a service because it has patients at the core of it, and that's what we do. And that involves a lot of collaborative working between other teams, between managerial teams, and particularly when you become a manager or when you become a senior clinician or a senior clinical leader, a clinical director, which I have been, is you have to look at strategic planning. You look at 1 year, you look at 3 years, you look at 5 years, you look at 10 years. So you're always looking further ahead and strategic planning, basically. And that's very, very important. And I'll mention a little bit about strategic planning when we talk a little bit about COVID. So it's all about developing this team through leadership, but in team building. You require them to, you know, to what the needs of your patients are. And you've got to inspire that team and manage that team so you get the best out of that team so you can deliver the needs of these patients. I do have technical skills. And these technical skills, I trained as a dentist to begin with. I've got reasonable hand-eye coordination, and then went back to medical school to become a maxillofacial surgeon. You need to be dual qualified to do that. So I have a plethora of technical skills, and I'm always looking to improve my technical skills. But the most important thing I think now is what we call the non-technical skills. And you're going to say, well, what's non-technical skills? And I'll come on to that in the next slide, really. But these are very important. And what they do, and I mentioned the word facilitate earlier on, and it's to facilitate this communication and teamwork and effective teamwork. And ultimately, it's about patient care. But it's not about just patient care. It's about safe patient care and the delivery of a safe environment for that patient to be in, because they get optimum care and safe care as well. And that's paramount, basically. So what do I mean by non-technical skills? Now, this has developed quite considerably over the past number of years, basically. And Professor Howardson, we talked a lot when we used to lecture together about the non-technical skills and what we classify as the human factors. And a lot of this is developed from the airline industry, basically, about how we go around managing are non-technical skills. And there's sort of 4 that have been brought out. And this came back in the mid part of the 2000s, basically. And this is a paper from Medical Education. And this was a rating system looking at surgeon non-technical skills. And we sort of focus on 4 things. It's situational awareness, is being aware of what's going on in your surroundings. And I'll talk about a situation where I actually lost situational awareness. I was doing a case as a trainee many, many years ago, and I was working in somebody's neck. I was doing a thing called a neck dissection, which is removing the lymph nodes in the neck. And there's a lot of exciting clockwork in the neck, as you can well imagine, the way of vessels and nerves. And I made a little hole in a vessel called the internal jugular vein, which is a rather large, important vein, which takes the blood from your head, neck, back to the heart. And I got my trainee just to put a sucker on it, basically. And I was so focused about trying to repair this little hole that time just went by quite considerably. I had lost all situational awareness of time. Time had gone, and it was my anaesthetist who pointed out to me, and he stopped me, and he says, Andy, I said, what is it? He says, look at the blood bottle, and the blood bottle had filled up by a litre and a half of blood. And I just had been so intent on stitching this tiny little hole that I was unaware of how much blood was being lost. And what I should have done is just cross-clamped the vessel itself and then just repaired it then. But I was just trying to be smart. So that's situational awareness. You become blinkered, you become task-focused, you become very task-centric. Decision-making. And as I say, we talk about decision-making and how it's very important. But that's decision-making having input from the rest of your team, not just you as the sole surgeon decision-making. The days of the decision-making of that is long gone. We thought it had, but a lot of you will be aware of the rogue surgeon Ian Patterson in the Midlands, who unfortunately mutilated a number of poor women and men with mutilating breast surgery. And he was making decisions which went unchecked, basically. He was allowed to do things with no checks or no balances and that. And this shouldn't be around. And the reason we got rid of that is we all remember the dreadful Harold Shipman in the days of him. He was making decisions as a single-handed practitioner. And as a result of Dame Janet Francis' inquiry, there was a lot of checks and balances put in place that surgeons or indeed doctors should not be left either alone or to make their own decisions. But unfortunately, this chap Patterson undo that. Leadership and communication, yes, very, very important that the two of them go hand in hand. But most importantly, it's team working. Team working is paramount important. So what have I got to do to ensure that the operating environment as a leader is a safe area? Well, I've got to set and I've got to maintain standards. I have to support my team, and that is everybody from the scrub nurse to my junior trainees to my anaesthetic colleagues as well. But I've got to be able to cope with pressure. And working in a high-stakes environment as an operating theatre, there is sometimes a considerable amount of pressure that goes on at that time there, and you have to focus a lot a bit there. So there are a lot of stresses and strains that go on with being a leader within the operating environment. This is a busy environment. This is where we work, and there's a lot going on here. There's 2 surgical teams there. There is indeed a lot. There's an anaesthetic team. There is support team. There's everybody there, but the chap in the middle here, he's keeping an eye on everything. He's overseeing everything that's going on here. Everybody's working in their own little team, but what's happening here, the chap in the middle here is actually overseeing everything. He's keeping an eye on what's going on. So he's overseeing everything, because everybody can get caught up in their own little task and become task-centric, loss of situational awareness and that. The amount of machines that you've got in there and the technology, counting them 1, 2, 3, 4, 5,
Andy,
6
can
machines.
I interrupt? Who is that chap in the middle? Is he a doctor? Is he a surgeon? Who is he?
He's a surgeon. He's a surgeon.
Right, okay.
So there's 6. There's 1, 2, 3, 4, 5, 6 different monitors that need to be monitored by different teams, basically. So that's giving you an overview, and you can see how busy it can be in there and how quite easy it is to lose situational awareness and then mistakes start to make. I mentioned I have to be a manager. This is the part of the job I'm not very good at, and I have had to learn over the years, basically. So as I said, leadership is motivating people, directing people, and taking them with you for the best outcome. But management is more concerned about a process. It's more about how we go about facilitating an objective or how we go about completing the task. So really, I have to be a manager and a leader. We have managers in the health system, and we sometimes have a love-hate relationship with them, but I'm blessed with having good relationship with my managers, and that's very, very important for constructive to have a constructive relationships, because in that way you're all singing from the same hymn sheet, and at the end of the day it all benefits the patient basically, and you have this common purpose. So I do have to have a manager, and managers is dealing with a whole host of things like interpersonal relationships, conflict, problem with colleagues, leave, financial considerations as well, because the NHS is not free. We have financial aspects as well to look at as well. So there's a whole bunch of other things, a plethora on the other side of the fence, as well as treating patients. I've also got to be a manager as well and manage my department basically around budgets, etc., staffing, all sorts of things. So that's the bit I was not good at. I'm a little bit better at it now, but as I say, it was a steep learning curve for me. Now, we know what this fellow is, don't we? We all knew that. We didn't know this before January, COVID. So what happened on March 11th, 2020? We knew COVID was around, but what actually happened is the World Health Organization actually made it a pandemic. So COVID became a pandemic in March 11th, 2020. Now, you've probably seen the news this morning. How much has COVID affected in the whole of the UK? This is hot off the press. This was taken an hour ago. The global deaths have hit over 1 million now. There it is, over an hour ago. It was 1,001,644 global deaths due to COVID. That's from the Johns Hopkins website. It's a live website. You can stream it. You can tell you how many people have recovered. Most of the deaths, over half the deaths, are between 3 countries, the USA, Brazil, and India. I've got over half the global deaths due to COVID. We are unfortunately here at 42,090 deaths. We've just gone over 42,000. On the left here, you can see how many global cases we've actually got of COVID. 33 million cases of COVID worldwide. Now, that's an understatement, an underestimate, and probably the global deaths is an underestimate as well. But this unfortunate figure was reached probably earlier on this morning, about 2-3. I checked last night, it was at 999,800 and something, and I checked this morning at 6 o'clock, and it went over the million. So it's not a good bit of reading, and it will continue to go up, unfortunately, basically. So COVID, that had a huge impact of it. It's a crisis. That's what it was. That's what it was termed in the health service, was a crisis. So how do we lead in a crisis? Well, there's a lot written out there, and we look towards the military, actually, and we look towards, and Brian will help me out here, we look towards the military when we do, and we look to more of a command and control situation, basically. So what elements do we look at? Well, certainly you've got to stay calm. Communication is paramount. That's the one thing we have, and I've certainly learned in the last 6 months anyway, is to communicate. We have to collaborate, not just within the hospital, but out with the hospital, with other hospitals as well. And with collaboration goes coordination. And we have to provide support to our patients, but support to our colleagues. Very, very important, our support to our colleagues. There was a significant strain put on our colleagues when COVID came along, long hours, working out with your comfort zone as well. A lot of people were redeployed. A lot of people were learning skills, for example, that they hadn't done before or had to retrain. So there was a learning curve for everybody, and it affected a lot of people in a lot of ways. COVID caused deaths. It caused deaths of medical staff. There was a lot of medical staff deaths. There was a lot of nurses that died. There was a lot of doctors that died. So we need to provide support and ongoing support, basically. And I must admit, our hospital that I work in, it's got that element of it there. So these sort of 5 elements I looked at is paramount to developing things through the crisis. So what happened in my domain is surgery? Well, we were told to focus on the critical issues, which was leadership and communication, as I said before. Our hospital capacity, we had to revisit that. So that was creating beds, particularly intensive care beds. PPE, which is personal protective equipment. There was actually when the COVID started in early March, there was a significant lack of PPE that was stockpiled. Pre-existing stockpiles were low, and actually the PPE we got was either unusable, was of the wrong kind, basically. So there was an initial element of PPE. And as I say, an unstable workforce. And what do I mean by that? Well, a lot of people were going off sick, people were having to self-isolate, and still people are having to self-isolate. It's got worse, actually. If you've got a child who's been sent home from school, that whole family has got to self-isolate. If you've got a family of 2 doctors, that takes them out of the workplace. So it's got a significant impact on the workforce. I remember my whole department was all in May, one of my registrars came down with COVID, and we all had to self-isolate, apart from myself, because I had not come in contact with them. So out of a department of 12, I was the only one. 11 had to go and self-isolate. So I had to run a department on my own for 2 weeks or 10 days. We have to optimise the outcome, obviously, for patients. We look at our providers as well, and also in the community, what impact it will have as well. So the Royal College of Surgeons said that the overarching principle really for us as surgeons and for the nation to get through the pandemic was to triage and deliver healthcare for maximum bed, and we had to look at as in a mass casualty scenario. We had to plan for that. And secondly, we had to protect and preserve the surgical workforce. If we can't do that, then we cannot offer a service, and that was paramount. This is the garment we have to wear with full PPE on, and you can imagine trying to operate on that for 8 or 10 hours. It's almost impossible to do that. We have to take regular breaks. You can't hear people, your communication goes down, so you have to repeat things. Your vision gets obscured because it fogs up and mists up and stuff like that. So it puts a significant strain on you when you're operating under these conditions. So we had to eliminate all our elective work, but we certainly hadn't compromised on emergency and cancer care. We had to reduce our outpatients to reduce the amount of footfall. So again, that was deemed to just essential services only. We had to remove our surgical decisions, so we had to prioritise them basically as emergency, urgent, and then what they call priority 2, 3, and 4, which means patients that had to defer. And these patients that are at priority 4, they are still on a waiting list. That's when you read all the stories at the moment. There are patients that are going to have to wait 6 months, 1 year for the surgery because they are priority level 4 patients and they're still waiting. Was it reading all the change in leadership style? Yeah, I think so. Certainly compassionate. We were more open. We had to be highly communicative. We had to speak to one another more and more. We had to be more task focused. We had to have a lot more energy. And I put resilience there because there was a lot of strain put on us during that particular time. And that idea of being resilient really came to the fore, certainly with me as well. We had to adapt. We had to look at different ways of doing things as well. We couldn't just be, I had to develop a change mentality, which I do have. And we had to base them on evidence-based strategies, which sometimes weren't there. We didn't have the evidence because we've never had COVID before. So it was very, very difficult to look at your own leadership style. So me as a surgeon, we had to maintain our service here, but we had to look at going out of our comfort zones. We had to look at doing different types of surgery. And then we had to look at doing things like airway and ventilatory skills. And we had to look at training. I'm okay, I can do tracheostomies and stuff like that. So for me, it wasn't so much of an issue really, but for some of my colleagues, it was. For our medical colleagues, obviously, some of them had to go into looking beyond their comfort zone as well, treating patients in the particular respiratory patients. So there was a huge learning curve and we were going beyond the edge of our normal practice. This is what sort of happened. We went through a preparation phase, which was getting everybody aware. We had the pandemic phase, and we're looking at having been in the post-pandemic phase, which is the recovery plan. But unfortunately now, we're going back into the pandemic phase, I think. I think looking at the way things are going in, just the conversations we're having in the hospital now, we're going back to this pandemic phase again. We've been trying to have a recovery phase, but I think we've been going back to that as well. So I think we're going back to a response attitude rather than a preparedness stroke recovery here. So this is where we're at, basically. I'm going to talk a little bit now. I've talked a little bit about COVID, but I'm going to talk about when leadership fails, basically. This is a fantastic guy called Atul Gawande. I've read his several books, basically, and he's a surgeon, basically, and he talks about when we make mistakes. Well, we all make mistakes. The error is to human, but it's to reflect on them and learn from them, basically. These are a couple of books I've read, and they've had a great impact on me, basically, particularly this one called Complications, the Surgeon Notes on Imperfect Science. We all have complications. The surgeon that tells you he doesn't have complications is a surgeon who's not operating. Simple as. So surgical errors, well, they're rarely a single mistake by one individual. Usually it's a systemic factor, and this is where I talked about human factors, and it contributes to about 80% of cases. Error management, looking at why errors, it recognises the fact that there is imperfections both in the individual, as in us, but more importantly in the systems. But we have to be ready to avoid them. We have to expect things to go wrong. We've got to look at the what if this, what if that, basically, and to mitigate them. We all read about this. These are a couple of scalpels left inside wrong organs. This is one I'm going to pick up on. This was an operation that was carried out in Wales at Llanelli, where the wrong kidney was removed. And you're going to say, how can somebody remove the wrong kidney? Well, we have this thing called wrong site surgery, wrong implant, and retained foreign bodies. These are what we call never events, basically. So they should never happen in the surgical arena. And this was brought in 2018. So this case here, this was happening down in Wales in Llanelli. The patient was admitted for a right nephrectomy. Nephrectomy means removal of a kidney. Clerical error, the submission step stated left. The operation list was transcribed from that to say left. The patient wasn't woken in the ward round in the morning to check on the correct procurative side. The side was not checked from the notes or indeed the consent form. The side was questioned by the consultants on the patient's arrival, but was not confirmed. Then he asked his SPR, that's the trainee, to carry out the operation. The consultant then mistakenly put the correctly labelled x-rays on the viewing box back to front, so he flipped them round, although they were correctly labelled. The consultant supervised the positioning, so he positioned the patient for taking a kidney out, it's prone, but the SPR did not check the side and was not alerted to this being the wrong side by noticing the normal pulsation in the renal artery was removed. There was 2 kidneys to remove. The kidney was removed and was what they call a dead kidney. It was a non-functioning kidney. It hadn't worked. But the kidney he actually was about to remove was a living kidney. You know, it had a pulse going into it. The renal artery, which is a big artery, had a big pulsation going into it. So you would have noticed that this was not a dead kidney, but he didn't know it. He just was on autopilot, remove kidney. He didn't think. There was a medical student in the theatre. There was a medical student. And the medical student said to the SPR, I think you might be removing the wrong kidney. Told by the SPR, oh, don't be silly, little girl. What do you know? You're wrong. The mistake wasn't discovered 2 hours after the operation. The patient unfortunately died because obviously, not just immediately, but further down the line. So why was it ineffective team working? Well, there was decreased vigilance there because by the consultant. There was because he wasn't operating. The SPR because the consultant was positioning. But the most important thing was dismissal of the student's concern. The student's concern was dismissed basically because they were of a low authority gradient. There's an authority gradient there. If you didn't have this authority gradient, Bundy pipes up, say, whoa, stop, I'm not happy here. Everybody stops and down tools, but this is not what happened. So what do? We reduce this authority gradient. We have briefings, we have a debriefing, we have team questions, we encourage everybody to speak up, we give feedback. We project objective feedback. We acknowledge our own mistakes, particularly if I do something wrong. I'm quick to put my hand up. And we talk about assertive trainings for people who are a bit quiet. So it's allow everybody to have a voice. I will not start an operation until everybody says, yes, Mr. Edwards, that's fine. I go around everybody in the operating theatre, and if somebody says I'm not happy, we just say, fine, let's stop. What are you unhappy about? And as Brian Howison used to say, there is no such thing as a stupid question. I'm quite happy to take a stupid question. So that's talking about the individual. What happens if the organisation fails? I know you remember this. This was a mid-Staffson horrendous problem that went on way back in the early 2000s to 2009. There's about 1,200 patients died of poor care, and this was a district general hospital in there. And this was leadership failure across the board, not just surgeons, not just managers, everybody. And there was a catalogue of disasters, basically, with patients left in soil, bedding, no access to food and water, staff shortages. But ultimately, there was failure of leadership in the hospital total. There was 2 inquiries. This was the final inquiry led by Francis Inquiry, QC, who looked at it. It went on for years, basically. And out of that, there were 290 recommendations, basically. So there was a greater openness, transparency and candour, i.e. we tell you when it's gone wrong. There was support. But at the bottom there, better healthcare leadership. That's important, most importantly, basically. And that was the ultimate thing there that came out of this one. So that's when it goes wrong at an individual level, but when leadership goes wrong globally, basically. And as Sir Robert Francis said, strong patient-centred leadership is needed to bring about transformation of organisational culture in the NHS. And hopefully it has done, basically. quick thing about the Royal College. It'll get off my surgeon's role. This is the Royal College of Physicians and Surgeons, which Professor Howieson was part of many years ago. We were funded in 1599 by Peter Lowe, who looked at us in 1560, trained in surgery in Paris, came over to Scotland, and we formed the college under a charter for King James VI of Scotland, basically. I have a different type of leadership style for this one. We're more focused about well-being, workforce inclusivity, engagement. We teach clinical skills, we teach non-clinical skills, we teach examinations and assessment. So my leadership style is very, very different from this. You're going to hear later on, I think, from the CEO from MenCap, who's the trust, that's a charity. We're a charity, so I'm actually a trustee as well. So I have to have a trustee's role, which is vision, which looking at our value, what we stand for, and looking at our strategy as well. This is a voluntary role. I don't get paid for this. I do this out of my own time, basically. There is a figurehead role, as I do. I travel around the globe, both UK. I have a national and international role, but we can actually influence policy. Governments speak to us, civil servants speak to us, and I've had a lot of work to do over the last 6 months with COVID, as you can imagine, basically. As I say, I've got multiple roles there. I lecture for the college. I take part in the ceremony. That's a ceremony in Bangalore where I was invited to hand out their degrees. Down there, I was in Hong Kong. We were examining there as well. We were at the UK as well doing an admission ceremony, and also we've got a meeting room. This meeting room is actually called the Lister Room. Professor Howieson will know that and recognise it well. It's named after Joseph Lister, and a lot of you will remember Joseph Lister. Who is he, he says? Well, none of us would be alive today without him if you'd had an operation. He developed antisepsis, basically, and he gave his first lecture on antisepsis while he was working at the Glasgow Royal Infirmary in the 1860s. At our esteemed college in Glasgow, basically. We have a room named after him. That's the Lister Room. That's where a lot of meetings I am hold and I participate in, and that's another leadership thing I do as well. So that's called the Lister Room. And I thought I would just sum up really with a quote from the great Joseph Lister. And this was something I thought was quite pertinent, basically. I trust I may be enabled in the treatment of patients always to act with a single good eye to their good. So at the end of the day, we're looking after patients, and patient safety is paramount. Hopefully I've given you a bit of a run through on what leadership means to me in the NHS, how COVID's impacted on it, and also indeed a little bit about my role in the college as well, basically. So quite happy to take some questions, or if not, I'm quite happy just to go away, basically. And thank you very much.
Well, Andrew, first of all, I just thought that was quite magnificent. Actually, I'm not saying that because you are a friend of mine. I just thought it was absolutely engaging in the whole, just fantastic. It was a real tour de force. What we try to do in the module, Andrew, is talk about not just theoretical leadership, but actually what it looks like, what it feels like, how do we do it. And these, ladies and gentlemen, I think we've got a huge insight into what leadership is to Andrew Edwards. So Andrew, thank you. A couple of questions, Andrew. How long does COVID go on for? Do you think, how long will this? I'm told that I remember in the 1980s, the whole AIDS thing, I'm told we still don't really have a vaccine for AIDS yet. And then my second question, I suppose, is if you go into the theatre to open up someone's face this afternoon, is there a recurring leadership challenge that's always there that you've always got to deal with?
Point number one, the COVID, how long will it last? Very good question. I think until we get a safe and effective vaccine, basically, Brian, I think that's the key to it, is vaccination. The government looked at herd immunity. What's herd immunity? Well, that's when up to 80% of the population are actually immune to it. So it's the young people protecting the old, for example. That's not going to work. Our government had tried to do that in the beginning and fell foul of it, basically. I think until we have a safe and effective vaccine, that's predicted at the later part of this year, early part of this year. That will be rolled out amongst our key workers, NHS worker, care home worker, elderly, people who are shielding and stuff like that. So COVID is going to be around in one way, shape or form for certainly a year or so yet anyway, until we've seen the back of it with an effective vaccine. So that's where I see it.
But if we still don't have a vaccine for AIDS, will this vaccine, I mean, what I don't understand about this, will I go, for example, into a pharmacist next February, some pharmacist will stick a needle in my arm
Yeah.
or whatever, and will that mean that I'll just be cured forever? I mean, I know that's a very general word, but I mean, if we're still struggling to get a vaccine for the AIDS virus,
Yeah.
will we get this vaccine quickly?
Yeah, and the AIDS virus is a completely different virus to a coronavirus. Coronavirus, there's lots of them. Coronavirus is the common flu virus, basically,
Yeah,
Brian.
yeah.
And we have a flu vaccine, of which I got mine yesterday. I had my flu vaccine yesterday. I didn't get much of a chance. I'm just about to go to the operating theatre, and my sister says, "Have you had your flu vaccine, Mr. Edwards?" "No." "Good." Woof, bang, in the arm. "Thank you very much." So that will keep me, and that will protect me against the coronavirus that normally circulate round about the globe at this time of year. And eventually, what COVID-19 will do, it will become one of these coronaviruses that will circulate round the globe as it does. Because it's a novel one and a new one, and we've never encountered it before, this is why it's becoming so virulent.
Yeah, thank you. That makes sense to me. Yeah, thank you. And the leadership challenge you have, Andrew, is there one?
Leadership, there's always a challenge every day, I think, Brian, and it's that you adopt your leadership style to the circumstances and stuff like that. Yesterday, what was an operating day for me yesterday? So we had our team brief in the morning. It was routine cases. Routine case. To me, it was a routine case, but to other people, there's no such thing as a routine case. We should not say that. Every case comes with potential harm, basically. So it's adopting your leadership style. I always go in there, as I say, my team I work with, they know my foibles. They know fine. And as I say, it's very, very difficult because we talk about human factors and stuff like that, and things do affect you because if I've slept in, which I very rarely do, I miss breakfast, I get caught in traffic, you come into hospital in a bad mood, don't you? Yeah, you've done it. You get on the train, you come in, you're late for a lecture or something like that. So it's hungry, anxiety, late time, the halt to call them. These are the what I call derailers, basically. You have to be aware of them, basically. And I'm always anxious not to come across like that because that impacts on the rest of the team. How you behave impacts on how the rest of the team behave, basically. They look to you.
30 years ago, my squadron boss did not go flying because he was aware that he was so angry. Something happened at work and he says, "I'm too angry to go flying today." And he declared himself unfit to go flying because he was self-aware enough to realise that the emotion of anger might make him dangerous in the cockpit. And I thought, wow, because he was aware that actually he was a danger not just to himself, but to other people around him.
See, that to me shows tremendous insight. Of course, somebody who's able to do that and make that decision, basically, which shows tremendous insight. And this is the problem when you have a surgeon who doesn't have that insight.
Yeah.
That's when mistakes will get made, basically. And the rogue surgeon, like I talked to before, Patterson, who thought he was doing absolutely no wrong at all. And this is a problem. Lack of insight. Huge problem. Huge problem.
Just before we take a couple of questions, Andrew, on BBC Two last night, there's a documentary started about Shipman and Hyde.
Oh, right.
Yeah, I think it's the first of 2 or 3 parts, so I'm going to record it. It was all about going back 20 years. Harold Shipman, folks, was a general practitioner who effectively played God, and for some reason he decided that he would end the life of elderly people. And I think he was probably the biggest serial killer in the UK. Is that, Andrew? Is it 250 people we think he died?
They reckon 250, but it's probably nearer 300, something like that, Brian.
And what is very amazing, it was a small community outside Manchester, northwestern England, not that far where Andrew is at the moment. And people trusted him. People thought he was this brilliant community doctor. And what had happened was people, the doctor, of course, he's not going to do any bad. People trust him. And it really, as I understood it, there was lots of inquiries. It really changed the field of medicine in terms of how doctors think and work. That was the case, Andrew, wasn't it?
It was indeed. I actually was a trainee in the region. I worked down in Tameside at the hospital next to his practice. Everybody thought he was wonderful. His patients loved him. They thought he was great. They called him Fred. Fred was his nickname, basically, although he was called Harold Shipman. And his patients loved him. They thought he was absolutely wonderful. I know I worked for a consultant colleague when I was a trainee who actually knew Shipman. And I was working in Tameside when this all came out. And I remember it came on the news in the morning, and I was assisting my consultant colleague, and my consultant colleague said, oh, good Lord, this couldn't possibly happen. Fred, I've known Fred for years. He's a Rotarian. He's on the Rotary Club. I've been to dinner at his wife's house several times. This is just poppycock, or as Donald Trump would say, fake news, but that wasn't around then. But then when it actually turned out that what he's done, my consultant colleague was gobsmacked, dumbfounded. He'd known this man for years, basically. But it all stems back from when he was at medical school. He was a drug abuser. Essentially, that's what happened. He abused drugs when he was at medical school, when he was a GP over in Yorkshire as well, single-handed practice. And this is the problem. He was in single-handed practice in Tameside. So there was no checks and balances on him, basically. They reckon it was because he'd seen his mother die of cancer, and she would die. She eventually died, I think, of opiate overdose. I think they gave her too much opiates, and I think that's probably triggered him off to do it. And that's how he was doing it. He was visiting elderly people in their homes and injecting them with diamorphine. And it was only picked up by the local undertakers. Basically, were wondering, why are all these people dying at home? If people die, but people die at home, but you don't die at home sitting upright in your clothes in your chair or anything like that.
At 2 o'clock in the afternoon.
Yeah. So
there's a documentary that was on last night. Andy, sorry, guys. Mindful, we've got 3 or 4 minutes left, and I know Andrew is very busy. Is there anyone who wants to put anything on chat? Anything at all that we want to say, because we don't get access to a consultant surgeon that often. Thanks, Dr. Edwards. It was a great speech and example of effective leadership style, Renata. Thank you. Yes, it was. It was just the whole idea of leadership changing as COVID. Anyone else, guys?
It's very true, and COVID's changed a lot actually in the healthcare. It's affected us quite considerably, and cases are rising. I mean, as of today, I think we've got 20 new cases in the hospital as of this morning. We actually got down to 0 at one point, which was a good few weeks ago, but it's on the rise again. So we're seeing this second wave, and we're a bit more prepared for it at the moment. And thankfully the problem we got at the beginning, there was a lot of too much conflicting advice came out. The civil service was a little bit caught off guard. And then the problem you've got is you've got SAGE, which is the emergencies, and then you've got COBRA. SAGE feeds into COBRA. So you've got the science. The scientists are in there they are advising the government. Now, the government should be taking best medical practice, but obviously at the end of the day, the government have got a balancing act between the economy and indeed the health of the. So that's what's going on. There's very much a balancing act, and that's why you're getting government sometimes flying in the face of what the medical experts saying, and the ones that are controlling it really. And I shouldn't be saying that, the civil servants. It's the Cummings of this world. These are puppet masters. Yeah, these are the string pullers. Yeah, I shouldn't be saying that. I'm meant to be apolitical. Yeah.
Andrew, 2 questions here. Yep. One from Shivani. You mentioned leadership. I don't know if you can see the chat function.
Yeah.
Yeah, it says you mentioned your own style and leadership. Would you say that you've had to alter your style to make your leadership strategy more effective as people learn differently?
Yeah, you're absolutely right. I mean, particularly in COVID. I mean, more people are. Leadership is a good leader adapts basically, and when people are learning, the learning's been different. I mean, in the days of me, it was read a textbook. It was very didactic, but these days we're we're online now, blending learning. We're very, very reflective learners now as well. A lot of my junior medical students are superb communicators. They are superb reflectors. I was very poor reflector because we were just not told. When I was told to reflect about something, I went, yeah, I've thought about it. Yeah, it's fine. I've reflected, basically. But reflecting is just more than thinking about it, basically. It's about writing it down. It's revisiting it again, looking at what it means to you, but more importantly, looking at what it means to other people. And that's what it is. It's how it's influencing other people. So yeah, I've had to change my style as well as people's learning. And that's the thing about leadership, is you should not get set in your ways. It's been about adaptive, and you have to adapt. And particularly in the last 6 months, we've had to adapt.
One last question, Andrew. How do you with emotions, especially when there's a failure on your team member side for recovery purpose, knowing there are lots of emotions in the theatre room? I think it's how do you deal with, I suppose, people who are very down or up, or
Yeah.
in a very
This is what I call, we have a thing called emotional intelligence. Yeah, Brian will probably know that. And I learned about emotional intelligence a number of years ago, and this is very, very, my emotional intelligence before used to be at my little finger. Nowadays, I am more up to speed with it as well. We find that there are feelings that go on. We don't blame anybody. It's not a blame culture. It's a learning culture. And that's what we have to do. That although something happens, we look at it, we reflect on it, we do not blame, we learn basically, and we support. That's the most important thing, is to support people through it basically. The days of the consultant standing in the operating theatre, ranting and raving like Sir Lancelot Spratt, throwing instruments all over the place and shouting at sister because this is now, these days are gone now. They are gone, thankfully, basically.
Okay, mindful of everyone's time, guys. Andrew wrote a vignette in the book. It gives another insight into surgery. Can we perhaps, through the chat function, express our gratitude to Mr. Edwards? Andrew, that was just magnificent, absolutely magnificent. Thank you very much. We'll catch up soon, but guys, perhaps you might want to say thank you to Andrew through the chat. Just brilliant, Andrew. A huge insight into your plan, and that's exactly what we're looking for. So thank you very much.
Brian, it's an absolute delight to speak to you and your students. Again, I'm happy if you can give my email address out, Brian. If anybody wants to contact me directly with anything, feel free.
Well, what I may say, Andrew, there's a few questions, lots of great stuff coming in there, Andrew. What I may do is get people to send me questions to me in my email. I'll forward them down to you, okay?
No problem at all, Brian. I'm absolutely delighted
Andrew,
to do that.
I'll let you go. Okay, guys, it's 10 o'clock. We probably need to go because you've got other things to do, but thank you very much again, okay? Thank you. Bye.
Take care. Bye.